back, and today we are continuing our exploration of knee biomechanics. Already we had the proximal and distal articular surface. We had yesterday discussion about genu valgum and varum, and now today we are going to discuss about the menisci of the knee joint. Of course, along with the menisci, we will be discussing briefly about the joint capsule of the knee joint. And today thus our discussion is on the meniscus of the knee joint as well as the joint capsule of the knee joint. This is Tony's tutorial. We are going to discuss about the menisci of the knee joint. Menisci of the knee joint. Alright. What do you mean by menisci, and why do we have a menisci or meniscus? You know that the tibial articular surface, which we did learn, or the tibiofemoral articular surface, is almost an incongruent one. Why? Because the convex shaped tibiofemoral condyles are resting on a relatively flat tibial condyles, right? And this makes the joint incongruent one, right? And now our body has to come up with some mechanisms which will make this joint congruent and stable like what we have in our knee. If we go on our exploration on the tibia, we see that the tibial condyles, we have medial condyle and a lateral condyle, medial condyle and a lateral condyle, right? And intercondylar tubercles. Okay, good. Now this is relatively flat, but we see that to the center it is slightly convex. Only slightly convex. We can't even say that it's concave. Sorry, to the center it is slightly concave. We can't even say it is concave, right? But to the periphery it is relatively convex. Okay, the periphery of the tibial condyles are convex. So this is going to make this joint highly incongruent. And now body has come up with a mechanism which is providing a specialized structure in between this knee joint, that is the lower end of the femur and the upper end of the tibia, which act like a cushion and enhance the stability of the joint, right? And that structures are known as the menisci. So if you want to define menisci, these are fibrocartilaginous structures. These are specialized cartilaginous structures, fibrocartilaginous structures, which are mostly disc shaped and act as a cushion between the femur and tibia. The femur and tibia. This is what the menisci is. This is what the meniscus is. And of course you have a lateral medial meniscus, and of course you have a lateral meniscus. On the medial tibial condyle you have a meniscus, and lateral tibial condyle you have meniscus. And now the shape of the meniscus is mostly disc shaped. So we have two meniscus, that is a medial and lateral. The medial menisci is semi-lunar in shape. General pattern is a disc-like, but medial menisci is mostly semi-lunar in shape. And the lateral menisci is mainly of a shape of a circle. But exactly speaking, it forms 4/5 part of a circle. That means if you have a circle like this, and if you divide it into how many portions? You divide it into 5 portions. This menisci has a shape of 4/5 part of that circle, right? So you can tell lateral meniscus is nearly circular, medial meniscus is merely semi-lunar in shape. Now let us see how the meniscus is arranged. I'm just demonstrating that for you. For example, you see this one. Right? Let us demonstrate the meniscus like this. See, this is how the menisci would be. The medial and lateral menisci would be like this. That means you can see that the concavity is increased. So the relatively convex or relatively flat tibial condyles are actually made into concave ones. If it is concave, it is more easy for the tibial femoral condyles to rest on it. It will increase the stability. Now let us see. See, right? See, the tibial condyles are immersed in or on that structure. Which is that structure? That meniscus. So this increases the congruency of the tibiofemoral joint. Okay. Now you see that each of the menisci is actually having two surfaces. This is known as the two horns actually. This is known as the anterior horn, which is seen anteriorly. This is seen as the posterior horn. This is the anterior horn of the lateral meniscus. This is its posterior horn. So each menisci has two horns or two ends, the anterior end and the posterior end. Anterior end is known as anterior horn, posterior end is known as posterior horn. And each of the menisci are opened towards the intercondylar tubercle. You can see that the menisci is actually opened into the intercondylar tubercle. In the condylar tubercle, there is no meniscus present. So both the meniscus are opened to the intercondylar tubercle. Right? And now one of the major action of this meniscus is it increases the concavity and helps in increasing the stability of the knee joint. Now let us examine in detail about medial and lateral meniscus. The medial meniscus, which as I told earlier is semilunar in shape, right? Semilunar in shape, right? It has two horns, that are the anterior horn and the posterior horn, right? And you have the lateral meniscus, which is actually 4/5 of a circle. 4/5 of a circle, right? And it is also having two horns, the anterior horn and posterior horn. And even we examine the meniscus, we understand that the lateral meniscus is larger than the medial meniscus. It is mainly because the medial femoral condyle, tibial condyle is larger. Medial femoral condyle is larger. So even though the lateral meniscus may not have a large cross-section area than the medial meniscus, it is relatively large because it sits on a small tibial condyle, lateral condyle. So we feel that, or we see that the lateral tibial condyle is larger than the medial condyle. Larger menisci is larger than the medial menisci. Okay? And is it good for us? Of course not, because we know that in our day-to-day activities the medial compartment is more loaded and medial compartment is more compressed, and there is the chance of osteoarthritis and articular cartilage damage more in the medial compartment. And if the menisci is less on that, this possibility increase. So these are the combination of reasons why the medial compartment osteoarthritis and damages are more common, even that it has no complete coverage of meniscus as it is covered in the lateral condyle. So it increases the compression and load that is acting on the medial tibial condyle or medial tibiofemoral joint. Now let us just draw a menisci. This is the semi-lunar shaped menisci on the medial side, and this is the nearly circular shaped menisci on the lateral side. Nearly circular shaped menisci on the lateral side. You see that this has a periphery. This is the peripheral region, and you have a central portion. And one of the unique features of this menisci are the periphery is thickened. The peripheral regions of the meniscus are thickened. And towards the center, they are thinner. And of course, they are not occupying this region. They are not occupying a portion of the articular surface. They are not completely covering the articular surface. They are covering only the peripheral regions or only a portion of the articular surface. Not completely covering the articular surface. You should note that. Okay. That's all about the general introduction of the meniscus. And you know that the function of the meniscus. Let us examine the function of meniscus. Can you guess what will be the function of the meniscus? of course, the first function is it increases the area of articulation, or it increases the articular surface area. When articular surface area is increased, what can happen? It increases the joint congruence, right? It increases the joint congruence, and you know that when joint congruence is increased, joint stability is also increased. Joint stability is also increased. So this happens as a chain. That increases the articular area by making it concave. They increases the joint congruence, and they increases the joint stability, right? These are the major functions of our menisci. Along with that, they act as shock absorber. They act as shock absorber. I told you that this is like a cushion between the joint, right? This is like a cushion. So this axial loading, the shock on that loading is actually absorbed by this meniscus. So they act as shock absorber, right? And this meniscus has a circumferential arrangement, right? You see that this is arranged like this, okay? What it actually do is, this meniscus will dissipate this force like this. So it will dissipate the force radially. That is, the meniscus has a role in dissipating the forces, dissipating the axial load. You know that the loading is from the top to bottom. The femur is going to load your tibia, and what the meniscus do? This meniscus will radially transmit or retransmit the force and weight bearing lines. That means the stress on this joint decreases. That is, it transmit or dissipate the force as well as decrease the stress on tibiofemoral joint, decreases the stress on tibiofemoral joint, right? These are the common functions of our meniscus. That is, it increases the area of contact or articular surface by making the condyle into a concave one, and it increases the articular congruence, and finally it increases the joint stability. Along with that, this menisci act as shock absorber, so that the greater amount of stress that is acting on the joint decreases. The menisci as having circumferential arrangement which equally transmit the forces, so that the stress that is acting on the joint is decreased, right? Also, it helps in the protection of our articular cartilage. Good. And let us see a lateral arrangement of the menisci. See, for example, let this be our femoral condyle, let this be our tibial condyle, okay? And we have a condition here, we have two cases here, right? Here you have, here you have the menisci, good? Here you have the menisci, here you don't have the menisci. What happens when there is loading, right? When there is loading, here the load has to be transmitted to a very small surface area. When you know that stress is equal to force by area, okay, I write it here, stress is equal to force by area. So what happens is, when the area decreases, the stress is going to increase. Here the stress that is placed on the joint increase, but here you see you have a greater surface area. So this helps in dissipation of the force like this, and ultimately by this the stress that is placed on the knee joint decreases. So that is the beautiful way menisci are arranged, so that it helps in the retransmission of forces as well as helps in reducing the stress that is placed on the knee joint. And this is why we often see that surgeons, in case of meniscal damage, rarely go for the total meniscectomy, right? They rarely go for total meniscectomy. Why? That is because this crucial role played by the meniscus. You know that in normal gait, our body weight that act on the knee joint or the load on the knee joint increases about 1 to 2 times of the body weight. Whereas if you are going for running, it increases about 3 to 4 times of your body weight. And if it is a landing, it increases 7 to 8%. Jumping, it increases 7 to 80%. 7 to 8%. 7 to 8 times of the body weight. And in this, the menisci takes about 40 to 55% of the load. Right? The menisci, they helps in transmitting or redistributing about 40 to 50% of this load. That's a great deal of work. And when that work is not there, it can ultimately result in greater articular cartilage damage and greater joint stress. That is why we often do not go for a total meniscectomy procedure if we have a possibility of preserving at least some portion of the meniscus, because this is very crucial as far as the knee joint is concerned. When there is an absence of meniscus or when it is removed, the load on the articular cartilage increases about 1 to 2 times, and load on the tibial femoral joint or the stress on the joint increases about 3 to 4 times. So that is why the meniscus are very crucial. Now, you have a patient with a meniscal injury and there is a different strategy that is followed when the meniscal injury is being dealt with. That is, it depends upon the location of the injury and the age of the patient. Why? That is because in our early years of life, that is before the weight bearing, the meniscus is richly supplied by the blood supply. That means all the parts of meniscus are supplied by the blood. But when weight bearing is increasing, when weight bearing starts, the percentage of the area that is supplied by the blood decreases. And by 50 years, you have only the periphery supplied by the blood supply. And the central region is avascular. It gets its nourishment through diffusion from the synovial fluid, right? And that is very crucial because this diffusion is actually increasing when there is an intermittent loading. When there is no loading, this diffusion is not going to happen. And that is the problem we see in immobilized patients. If they are immobilized for a long time, this diffusion do not happen. Intermittent loading do not happen and diffusion will not occur. It can lead to the damage of the meniscus and articular cartilage. Okay? And that's what we were saying. By the 50 years of age or middle of your age, the meniscus, the periphery is only going to be supplied by the blood vessels. And that is getting it from the joint capsule and synovial membrane. The center region is actually avascular and it is going to be receiving its nourishment through the diffusion. And that is why meniscal damages are difficult to hear. Of course, you know that the peripheral region, if it is damaged, they can go for the inflammatory process, they can reconstruct themselves. But in the central region, if there is a damage, there is absolutely no possibility of a reconstruction or self-healing, right? And that is very important and we have to note it. And finally about the meniscus, I want to mention that the menisci, the periphery of the meniscus is actually having a large number of nociceptors. And what happens if the nociceptors are increased, number increased? That is why you have an increased pain, or that is why you sense pain when there is a meniscal damage. And along with that, the menisci has some mechanoreceptors, such as your GTO. What is GTO? Golgi tendon organ, Ruffnian corpuscles, and Tasnian corpuscles. These are some mechanoreceptors that are seen in our human body, and they are richly seen in the periphery of the meniscus. And what does mechanoreceptors do? Mechanoreceptors helps in the proprioception, and that is why when you have a meniscus injury, these mechanoreceptors may go for its damage and the proprioception or joint position sense is decreased. So you see that this is a very simple structure like this, okay? It's a very simple circular straight or semilunar shaped structure, but they are doing some great role in our knee joint, right? That's the greatness of meniscus. And of course you need to study about the connections of meniscus, which we will deal after going through the ligaments, because it's related to the ligaments. For simply, if you know that the anteriorly the meniscus are covered by or lined together by transverse ligament. Transverse ligament is a ligament that connects both meniscus anteriorly. Then the meniscus has relation to anterior cruciate ligament, posterior cruciate ligament, medial collateral ligament, and so on, which we'll discuss after discussing about the ligaments of the knee joint, right? And now we are going to discuss about the knee joint capsule. Now we move on to the joint capsule of the knee joint. But let me ask you, why do we need a joint capsule? We studied about a menisci, which is increasing the articular congruence. But the articular congruence is increased by meniscus is only about a percentage. But a more amount of congruency is needed in the knee joint, considering the arrangement of knee joint. And that is actually provided by your joint capsule, all the associated structures, the capsule, the ligaments, and of course muscles. In knee joint, muscles also plays a role in its stability. Here we are going to discuss about the joint capsule of knee joint. Why do we discuss the joint capsule? This is the beginning of our discussion into the ligaments of the knee joint, which are very crucial. To understand the ligaments, we need to understand about the joint capsule. And what are the functions of joint capsule in knee joint? The joint capsule in knee joint serves three functions. The first function I mentioned already, that is the role in stability. Right, the role in stability. For example, you have a knee injury and your ligament or capsule is torn or teared, or it's gone for damage. The stability at the knee joint is completely altered. The muscles alone cannot provide that stability. So this has a very crucial role in the stability. The second role that is played by is in the proprioception. How? And sensory feedback. How? As our meniscus is having nociceptors, here also you have nociceptors as well as mechanoreceptors, mainly the Ruffinian corpuscles and Pacinian corpuscles. In your meniscus, it was Ruffinian corpuscles, Pacinian corpuscles, and Golgi tendon organ. Here you don't have the Golgi tendon organ. All other, that is the Ruffinian corpuscles and Pacinian corpuscles. This helps in proprioceptive feedback, and this helps in sensory feedback. Here the proprioceptive feedback is actually done by a reflex stimulation of the muscles or reflex activation of the muscles. You don't need to worry about that. Just remember, the mechanoreceptors helps in the stability as well as proprioceptive feedback of the knee joint. Right, and the third function, you know that the knee joint is having a synovial membrane and a synovial fluid. This joint capsule creates a cavity in which the synovial fluid can be situated very efficiently, or it holds the synovial fluid together. It creates a joint cavity that encompasses or that covers or that holds the synovial fluid. So these are the three important functions of knee joint capsule, right? That's a crucial function. Now let us examine the knee joint capsule. If we examine the knee joint capsule, we see a unique feature which we have mentioned in our earlier class. That is, in knee joint you have tibiofemoral joint and patellofemoral joint. Both these joints are actually covered by a single knee joint capsule. The tibiofemoral and patellofemoral joints are covered by a single knee joint capsule. Okay, and now this joint capsule is seen, or you can simply say, it acts or starts from the inferior aspects of the femur to the superior aspects of tibia, and it covers the joint completely. Of course, it has some speciality which we will discuss later, or simply it covers the joint like this. Of course, in our biomechanical classes and anatomy classes, we often forget about the joint capsule, seeing it's not much significant. We go on to the ligaments which are mostly said and heard about, right? But joint capsule is very important here, and in all joints, especially in the hip joint, it's actually providing the capsular ligament stress or capsular ligament is forced to prevent the extension. We studied that. Similarly, here also it's important, it's covering the joint completely. It starts from the inferior aspects of the femur to the superior aspects of the tibia, right? And posteriorly, if you see, this is attached to the posterior margins of the femoral condyle and intercondylar area. This is attached like this, okay? It is attached like this, and inferiorly to the tibial condyles. So posteriorly, the capsule is attached to the margins of the posterior margins of the condyle and intercondylar area and stretches from there and is attached to the tibial condyles. And medially and laterally, your capsule is reinforced. In both this direction, your capsule is reinforced by capsular ligaments, which we will study next session. Which are the capsular ligaments? So it is reinforced by the capsular ligament. And what about the anteriorly? See, anteriorly you have here the patella. Here you have the quadriceps muscle, and the tendon of the quadriceps and patellar tendon is seen anterior in the capsule. So anteriorly there is the tendon of the patella and the quadriceps tendon, right? And anteromedially and anterolaterally, that is in this direction and this direction, the capsule is called, or capsule is called by a specific name known as the medial, anteromedial. Medially it is known as the medial patellar retinaculum, and laterally it is known as the lateral patellar retinaculum. Is it confusing? I will tell once again. That is, the capsule of the knee joint is reinforced laterally, both sides, laterally and medially, by the capsular ligament. Posteriorly also it is reinforced by the capsular ligaments. Okay, the capsule is actually stretching from the inferior aspect of the femur to the superior aspect of the tibia. And posteriorly, the capsule is extending between the posterior margins of the tibia femur and the intercondylar notch, and finally inserted into the tibial condyles, right? And now in the anterior sides, here you have your patella resting. Here you have your patella, right? And the capsule is having this anteriorly. There is a tendon that attaches patella to the quadriceps tendon, and here you have the patellar tendon. So anteriorly, the capsule is having the patellar tendon and the quadriceps tendon. And anteromedially in this side and anterolaterally in this side, this capsule is designated as the medial and lateral patellar retinaculum. And finally, this patellar retinaculum is known as the extensor retinaculum of the knee, right? The extensor retinaculum of the knee. That is, you have the knee joint like this, okay? You have the knee joint like this, okay? And here you have the patella, here you have the quadriceps tendon, here you have the patellar tendon, okay? Here, in the anteromedial side, this is a medial and this is lateral. In the anteromedial side, the capsule of the knee joint is known as the medial patellar retinaculum, and anterolaterally it is known as the lateral patellar retinaculum. This is the lateral patellar retinaculum. Patellar retinaculum. Medially, this is known as the medial patellar retinaculum. Patellar retinaculum. Good. And both these are together known as the extensor retinaculum. This plays a crucial role in the stability of the patella, which we will discuss later. We will discuss all about this in the coming sessions. You need not worry, but just understand the capsule is anteromedially and anterolaterally designated as the patellar retinaculum, medial and lateral patellar retinaculum. And now the capsule of the knee joint is actually made up of two layers. That is the outer fibrous layer or inner or deep synovial layer. Outer fibrous layer and deep or inner synovial layer. This layer lines the synovial membrane and has the synovial fluid. And this layer is the outer layer which is providing the passive stability, or it is providing the stability. In the next coming session, next video, we will discuss about this outer layer and inner layer and the biomechanical peculiarity of the layer. Along with that, we will have an interesting discussion about the medial collateral ligament and lateral collateral ligament, right? So let us summarize on this session that we saw about the menisci, the role of menisci and the importance of menisci and the mechanoreceptors and nociceptors in the menisci. Then we had a brief introduction about what was knee joint capsule, the role played by the knee joint capsule, the three important roles played by the knee joint capsule, and we studied the capsule is made up of an outer fibrous layer and an inner membranous layer or inner synovial membrane. Okay. And the capsule is attached from inferior aspect of the femur to the superior aspect of the tibia. Posteriorly, it is attached to the posterior margins of the tibial condyle, femoral condyles and intercondylar nodes to the posterior margin of the tibia or tibial condyles. And laterally and medially, this is reinforced by the patellar tendon, the capsular ligaments. And anteriorly you have the quadriceps tendon and patellar tendon, and anteromedially you have a medial patellar retinaculum, and anterolaterally you have the lateral patellar retinaculum. This is the anteromedial side. Here you have medial patellar retinaculum, here you have lateral patellar retinaculum. That's all about this session. If you like the video, please click the like button and don't forget to subscribe to the channel to stay updated with all the latest updates in our channel.